Well, welcome everybody. My name is Dr. Ross Hauser. I'm coming to you live from Fort Myers, Florida. I'm a little bit hoarse, coming down with a little bit of a respiratory infection. So if I clear my throat or whatever, I apologize. But the talk today, over the next 2 hours, you will see things that you've never ever seen. Like you'll hear things and you'll learn things that can change people's lives. Most people are unaware of the fact that all the vital centers in the body, the autonomic nervous system, the brain stem, where your blood pressure control is, where your nausea center is, and like I said, the autonomic nervous system, including the vagus nerve, you'll see figures and illustrations that show that it all comes together in a very narrow part of the body, which is the upper cervical spine. And I would just like to thank my team, Travis, Nicole, Ben, Mandy, who are here with me today, Marion, Rachel. I think I got everybody, Travis, Nicole. Travis made this upper cervical model. So this is the skull, this is C1, C2, and obviously this person has a very loose upper cervical spine. But what you'll see today is that the vagus nerve and the autonomic nervous system sits right at C1, C2, and that's why upper cervical spine instability is the most disabling of all the joint instabilities, because it destroys or causes malfunction or dysfunction of the autonomic nervous system. And as we'll learn, the autonomic nervous system controls everything in your body, your heart rate, your pulse, the functioning of your liver, whether or not your endocrine glands make hormone like cortisol or thyroid hormone. It controls whether nutrients are absorbed from your digestive tract. So the ramifications of upper cervical instability are enormous, but there's hope. And one of our slogans at Caring Medical is hope practiced here. Doug Skinkis is listening today. He ran Caring Medical for 10 years, so welcome, Doug. He made a wood burning that sits in one of our facilities that says hope practiced here. And the hope is that you can stabilize the upper cervical spine by tightening the ligaments with what we call H3 Prolotherapy. People come to us. Recently, I had a patient who said I was the 102nd clinician that they had seen. So I'm often the doctor of last resort. And you can see from this illustration that people see a myriad of healthcare providers, including surgeons, chiropractors. They get various drugs, massage, medications, radio frequency, and all these things are treating the symptomatology of upper cervical instability, but they do nothing to tighten the ligaments or stabilize the upper cervical spine. There is one treatment that can stabilize the upper cervical spine without a cervical fusion, and that treatment is prolotherapy. Next. This kind of is a good illustration of what I just said. When you have a neck ligament injury, and the ligaments are what connect the bones, that's a really key point. The ligaments are what connect the bones. So if a ligament is stretched out, torn, incompetent, the bones are going to move in a manner in which you don't want them to. There's going to be excessive motion. That excessive motion can lead to a swollen joint, muscle spasm, nerve entrapment, subluxation, which is a bone moving out of alignment. Eventually, the body tries to stabilize the joint by overgrowing bone spurs, and obviously, it can screw up the nervous system where you can get balance issues. So a person who has a swollen facet joint, for instance, in the neck, they might go to an interventional pain specialist to get a cortisone shot. If they have muscle spasm, they might work with a physical therapist. Obviously, if there's occipital neuralgia or some kind of radiculopathy, cervical radiculopathy, a pinching of the nerve, the person might go to a neurologist, but none of these treatments or clinicians do anything to resolve the underlying cervical instability. So because of that, they never get full pain relief. So if you have unusual symptomatology, let me just say that you have symptomatology where nobody has explained why you have it, you probably have upper cervical instability as the cause. This is just a client. So a client came in and they had had a myriad of medications and treatments for these 16 different complaints. They had a pinched nerve, degenerated disc, depression, anxiety, ear infection, vocal cord dysfunction, dizziness, brain fog, nausea, reflux, swallowing problems, poor digestion, irritable bowel, constipation, Hashimoto's, thyroiditis, and blurred vision. They actually had 2 more other symptoms, but apparently we couldn't get that on the slide. And if you look at all the different treatments they had a cervical laminectomy to quote unquote unpinch the nerve. They had tubes placed in their ear. They had dilation of their esophagus. They had, various laser surgeries, all different kinds of things. And if you talk to the person, everything they did, it helped a tad, but they would tell you that the condition is absolutely progressing. And anybody who has pain almost always progresses. And the reason it progresses is that instability of a joint, upper cervical instability, is a progressive disorder. Think of it this way. If you have a door hinge, like a cabinet door, a kitchen cabinet door, and one of the screws is loose on the hinge and you open and close the door, what's going to happen to the next screw? That screw gets loose. Once that hinge is loose, what happens to the next hinge? The next hinge gets loose. So cervical instability is a progressive disorder. The good news is that prolotherapy can resolve it. Now, I like this Occam's razor. Occam's razor just means that the simplest solution is the correct one. So I guess my question to everybody listening is, does this person have 16 separate diagnoses, or could it possibly be that they just have cervical instability at the C1, C2 level, which is screwing up their nervous system? And then because their nervous system is not functioning correctly, then they have this myriad of symptoms. And I hope at the end of this talk, you'll be like, oh my gosh, my friend, myself, my mother, my child, it's like, oh my gosh, they got upper cervical instability. And again, there's hope, and that hope is there's ways to document the upper cervical instability, which I'll show you. There's ways to document if your nervous system isn't functioning correctly. I'm going to give you clues that you can take home today to see whether or not you have a vagus nerve issue. So that's going to be kind of cool. And you're going to see the ways at Caring Medical that we document that the cervical instability not only is screwing up the nervous system, but it's actually screwing up the blood supply to the brain. And almost all the people who have upper cervical instability, they have an amazing amount of brain fog and other symptoms like inability to concentrate. And if you can't concentrate, eventually you're going to get anxiety or depression. So there's lots of people out there that actually have a structural depression. It's not a chemical depression, it's a structural depression from cervical instability. I've had a great career treating a lot of different clients. This is a client who did really, really well. He was extremely grateful for the prolotherapy that he received. Next. I get consults from all over the globe. This is somebody from Europe. This is only a 15-year-old. And I guess the point I want to make from this figure, and I'm gonna take the cursor here. Now, when we talk about the cervical curve, so here's C7. Watch my cursor. See how there's like a C? See, this young person C1 is supposed to be way over here. So when I use the term cervical dystructure, so that's actually a term that I came up with, cervical dystructure, it means that the cervical curve, the supporting structures of the cervical spine are basically destroyed. So this person, this 15-year-old has already had 2 cervical fusions, and you'll see that they don't have the normal cervical curve, they have an opposite curve. Instead of the curve being lordosis, that's the C, they have the opposite curve, which is called kyphosis. So the problem with a cervical kyphosis is that kyphosis can stretch the spinal cord. So the spinal cord, when you don't have your cervical curve, the spinal cord can get stretched anywhere from 1 to 3 inches, which of course can cause spinal cord cellular death. And then in the front of the neck here, you're going to see illustrations that we've been working on here that shows that your autonomic nervous system is right in front of C1, C2. So when you have a reversal of your cervical curve, it disrupts the normal functioning of your autonomic nervous system. So that means the nervous system supply to your stomach, to your large intestine, to your small intestine, to your thyroid, to your liver, to your spleen, right? The spleen is your immune system, right? People can't figure out why your immune system is all screwed up. They can't figure out why you have rheumatoid arthritis, why you have Parkinson's disease, why you have fullness, you have head fullness, head pressure. The ophthalmologist can't figure out why you have blurry vision. You have Parkinson's disease. You have multiple sclerosis. You have neck pressure, neck pain, and muscle tightness that never goes away. Well, I can tell you the reason that it doesn't go away is because the underlying cause. See here at C6, C7 right here. This young person now has severe instability at C6, C7. So instability in the cervical spine can easily be documented by motion X-rays. So I'm going to use the term dynamic, functional, and motion. All those things mean is that the person's moving. So when you get an MRI and you lay flat, often instability is missed because you don't have instability when you're laying flat. You have instability when you put your head forward or you tilt your head to the side. So you can only document the instability when you're moving. So those scans are called functional scans, motion scans, dynamic scans. Next. If you have a question, please send any questions during this talk to Facebook Live. And Ben's here and he'll reiterate the question to me. So you can even now start asking questions. If after the talk or if somebody gets this after the live segment, you can email me your case or any questions to drhauser@caringmedical.com. I'm always happy to answer questions. Or you have scans you want me to review, please feel free to email my team at drhauser@caringmedical.com. Next. That's my wife, Marion. She's a registered dietitian. She functions as our CEO. She's much prettier and much more intelligent than me. We started Caring Medical actually in 1991. In 1993, I started working with Gustav Hemwald, the world expert in prolotherapy. I joined him when he was 83 years old. He died at the age of 90 in 1998. I've been doing prolotherapy since 1993. I've probably done something in the order of 75,000 to maybe 80,000 patient visits in prolotherapy. So, and I've probably given somewhere in the order of 4 million to 5 million in prolotherapy injections. Marion and I have written 9 books and have over 30 scientific publications on prolotherapy and natural health. I'd really encourage everybody to look at some of the articles that we've written. They're available at caringmedical.com. Yes?
Dr. Hauser, we have a question.
There's going to be a question.
One of our live viewers. Would cervical instability also cause insomnia?
Yeah, that's a great question. Could cervical instability cause insomnia? Well, it turns out, guess what? The pineal gland, which makes melatonin, the pineal gland, which makes melatonin, depends on vagus nerve input. So what happens is when you have upper cervical instability and you don't have normal vagus nerve tone, basically it's what I call cervical vagopathy. Cervical vagopathy. You don't make the normal amount of melatonin, then of course it leads to problems with the circadian rhythm, and of course you end up getting insomnia. A lot of insomnia is actually structural insomnia from upper cervical instability. I run the Hauser Neck Center here at Caring Medical, Florida. In beautiful Southwest Florida, we do service clients from all over the globe. Next. This is some of the stuff we do. So I'm going to just go through this. This is me taking a temperature. When you have cervical instability, especially upper cervical instability, your temperature regulation is not normal often. So if you're somebody who has sweating in one part of your body and nobody can figure out why, you probably have upper cervical instability. If you feel your face flushes or you get itching on one part of your body, it's probably from upper cervical instability. We do various tests. We do physical tests. I can measure, this is me actually doing some injections under ultrasound guidance. So we have high resolution ultrasounds in the office. We have transcranial Doppler. We have extracranial Doppler. This is what we call the Frankenstein Frankenstein device that we put on people to look at brain blood flow. This particular person came over from Europe, and then he had unbelievable amount of symptoms: swallowing difficulties, dizziness, ringing in the ears, vertigo. And then we found that with a certain motion, his blood supply to his brain stopped, and we're going to show you that later. It's unbelievable. It's unbelievable the stuff we find in the office. Okay, next. This is Dr. Hemwell. So I joined Dr. Hemwell in 1993. This is Dr. Hemwell and Dr. Hackett at a physical medicine meeting in the 1960s. We call our kind of prolotherapy H3 prolotherapy for Dr. Hackett, Dr. Hauser, and I'm Dr. Hemwell. I'm Dr. Hemwell's associate. I took over his practice when he retired. For anybody who isn't familiar with prolotherapy, prolotherapy is a treatment that stimulates the body to repair painful areas. We basically inject substances that attract the various cells that do the healing in the body. So some of the substances that we inject can be minerals, can be ozone, hypertonic dextrose, which is the normal sugar, platelet-rich plasma, and even components of the bone marrow and fat. The body heals over a 4 to 6 week period. We know this to be true. You sprain your ankle, it heals over 4 to 6 weeks. You break your bone, the doctor says, hey, you got to splint it or wear this cast for 4 to 6 weeks. So Dr. Hackett coined the term prolotherapy, so that's him. He named it after fibroblastic proliferation. The fibroblasts are the cells that grow the ligaments. So what happens after prolotherapy is there's a massive rush of cells into the area, and then the ligaments start tightening and thickening. Once the ligaments tighten and thicken to the point where the joint is stable, the pain goes away, and so does all the myriad of symptoms, including the autonomic nervous system dysfunction. Anybody who's been diagnosed with POTS, postural orthostatic tachycardia syndrome, mast cell activation syndrome, dysautonomia, you definitely got to get assessed for upper cervical instability, because these things can get resolved, can get completely resolved with prolotherapy. I do want to say it's not like I have 100% success rate, so I want to say that right up front. Really, if you think about it, only God is 10 out of 10. The rest of us do the best we can. I've published various papers. You know, when somebody comes in, we always say we're responsible for 50% of healing, but the person is responsible for the other 50%. It means that if a person bends forward, like they look at their cell phone, and that's the position that they get instability from, then obviously after prolotherapy for a time, it might be 1 month, 6 weeks, 2 months. You can't do that. So if somebody does that motion, they stretch the ligaments. So they stretch the ligaments in between visits. The prolotherapy is not going to be effective. So if somebody comes for prolotherapy, we often say you got to be all in. You got to be willing to do the whole program. And some of the program, it's a little bit hard because you might have to brace your ankle or brace your knee, or in the neck, you might have to brace your neck for a certain period of time. Next. Our slogan is where the world comes for prolotherapy. We have a map. I have great patients. So I've learned what I've learned really because of the patients. So I have some of the best patients in the world. They care about me. They care about the staff. I kind of call them the unsung heroes of team caring. Like, they're out there in droves. They're on the chat rooms. They're on Facebook Live. They're on Facebook, trying to get their friends and family to realize that they don't have to suffer with migraines, with head pressure, with facial pain, with trigeminal neuralgia, with Meniere's disease, with fibromyalgia, with irritable bowel syndrome, with rheumatoid arthritis, with all these things. If they just come and get an assessment for cervical instability, and if they have cervical instability, then there's a treatment for it, which is prolotherapy. One of my patients gave me this cape called Injectoman. Next. There's a myriad of ligaments. These are just some of them. Thank you to Dr. Rosa, who gave me some of his slides. You can see there's the main ligaments that get lax in the upper cervical spine are the capsular ligaments. So in the office, we do functional tests. We do motion tests to see which ligaments are lax. So we test the transverse ligament. So the transverse ligament, that's right here. That's what holds the dens in place. We test for the alar ligaments. We test for the capsular ligaments. Many people have been diagnosed with alar ligament injury and they actually don't have it. Like, in other words, when you do a functional test on them, the alar ligaments are fine. The most common ligaments that are injured with upper cervical instability are the capsular ligaments. To treat the capsular ligaments with prolotherapy, we do it under Xray guidance or ultrasound guidance. But just know the dura connects to C1, C2, and there's just a tectorial membrane and all kinds of ligaments attached there. And next. So before we get into the various kinds, how you actually injure ligaments, just know that what gives the strength to ligaments is the type 1 collagen. So this is a study on the medial collateral ligament, and you can see that it's primarily type 1 collagen and not type 3 collagen. So the type 1 collagen is stronger than steel in a gram for gram analysis. So that's how strong type 1 collagen is. For our patients and prospective patients who have been diagnosed with joint hypermobility syndrome, hypermobility spectrum disorder, or Ehlers-Danlos syndrome, just know that the genetics of Ehlers-Danlos syndrome is normal for type 1 collagen. Ehlers-Danlos syndrome often has a type 3 or type 5 collagen deficiency or mutation. So people with Ehlers-Danlos syndrome respond great to prolotherapy because what gives the strength to ligaments is the type 1 collagen. And people with Ehlers-Danlos syndrome, their type 1 collagen is just stretched out, but the genetics is normal. So what they need to get rid of their joint instability, their mast cell activation syndrome, their POTS, their brain fog, is tightening and thickening of their ligaments by prolotherapy. Anybody who's had a ligament injuries typically only heal 60 to 70%, even in the best case scenario. Prolotherapy stimulates ligament fibroblasts to synthesize type 1 collagen. Prolotherapy can return ligaments back to normal strength. So if you are going to a chiropractor and your vertebrae always subluxes or goes out of alignment, you should consider getting an assessment for prolotherapy because it means that your ligaments are lax. Interestingly, the word ligament or the word collagen, which makes up ligaments, comes from the Greek word for glue, and the word ligament is derived from the Latin word for rope. So I think that's a good way to look at it. Ligaments are the glue that hold the bones together, and when the ligaments can't hold the bones together, guess what happens? The muscles tighten. So that's through the ligament muscular reflex. So if you have tightness like right here, like you want somebody to smash into, right below your occiput because it's always tight, always tight, always tight, just know you have cervical instability, upper cervical instability, and those suboccipital muscles are contracting because the ligaments are incompetent. So that tightness is only going to go away until the underlying ligaments are tightened. If you have recurrent joint swelling in the knee, in the ankle, in the facet joints of the neck, you have upper cervical instability and the body is swelling the joint to stabilize the joint. Long term, when you have cervical instability, long term, the excessive motion causes the discs to degenerate and for bone spurs to form. So the cause of bone spur formation or degenerative disc disease is cervical instability. So the treatment shouldn't be a disc replacement or discectomy. The treatment should be prolotherapy to tighten the ligaments because ligament laxity, ligament incompetence was what caused the degenerative disc disease. There's 3 ways that the neck ligaments get stretched out. Obviously a car accident, a football when 2 people collide. Post-concussion syndrome is not from a brain injury usually, it's from an upper cervical injury. So I'm going to get the model back. So in other words, when 2 heads collide, what happens is there's a twist. So when you have, like in soccer, you have in football, or you knock your head, like you lose your balance or you knock your head on something, when you hit your head, the head turns really quick, and that quick turning, it causes an injury in the upper cervical ligaments. So if you've had a head trauma or you've had post-concussion injury, you should get an assessment for upper cervical instability because that's what's causing your problems. It's an ongoing problem. And remember I said upper cervical instability, that's a progressive disorder. The number one cause, I don't have my cell phone with me, but most of us are living a face down lifestyle. That's what I cause it. When you look at your cell phone or you're hunched over the computer, you get creep, you get slow stretching of the ligaments. That's the number one cause of ligament laxity today. You could not have a car accident and you could end up with horrible, horrible upper cervical instability just because you're addicted to your cell phone and you're on the cell phone bent over for hours and hours. Remember, we have muscles in the back of our neck, but when you go like this, that's a passive motion. You don't really have muscles that are putting your head down. It's a passive motion. And that passive motion down for hours and hours stretches the ligaments in the back of the neck. Then about 10% of our clients we see because they've had high velocity manipulation causing an injury to their C1, C2. That can be from a chiropractor or it can be by self-manipulation. So if you're somebody who self-manipulates, trust me, you have cervical instability. I would say this, if you have cracking, clicking, grinding in your neck with head motion, you have cervical instability. So if you have a lot of symptoms from that, you're going to have to get a scan, a motion scan, to document the instability. Next. So, there's lots of different motions that can injure the cervical spine. Somebody who swims, right? They're rotating their head 1,000,000 times. Somebody who plays soccer. Somebody who's hunched over a computer, right? Whenever I go to Starbucks or I go to a cafe and I see everybody hunched over their computer, their cell phone, I'm like so happy. I'm like, oh, business is going to be really good in the future. So if you don't want to get prolotherapy in your future, you have got to be looking up. You have got to be looking up. Looking up causes you to have your cervical lordotic curve. When you have the normal cervical lordotic curve, you decrease the stress on your spinal cord, on your autonomic nervous system that sits in the front of the neck. But if you go like this and your cervical curve changes and it reverses, you have tension on your brainstem, right? You have tension on your brainstem, so the nausea center gets under tension, then you feel nauseated all the time. You have tension on your balance center, so then you feel woozy all the time, almost like you're on a boat and everything's spinning, everything's like wavy. Or you have blurry vision and you look at an object and you look away and that object is still there. Or parts of the vision are dark, or you get spots, you get floaters. All these things can be from cervical instability. Next. So this is just a graphic that we had made that shows that working on the computer, the cell phone, it's causing slow stretching of the ligaments. Next. High velocity manipulation, or anybody who cracks their neck. The record at our office was I saw a client who, prior to seeing me, he had manipulated his neck and his thoracic and his lower back 677,000 times before I saw him. So, because again, it's a progressive disorder. So if you have to manipulate your neck or your back more and more times, it means you're getting looser and looser and looser. So it's only going to get worse. You should get a digital motion X-ray, which I'll show you, and you should get prolotherapy. So this is actually what happens. See how here the vertebrae are together, here they're stretched out. When they're stretched out, the ligaments are stretched, and those posterior ligaments are what causes cervical instability, especially upper cervical instability. Oh, just wait a second. If you look at this model, there's a disc C2, C3, C3, C4, C4, C5, C5, C6, C6, C7 has a disc. There's not a disc between C0, C1, and C1, C2. What it means is that disc from C2 to C7, that disc gives some stability to the lower cervical spine. C0, C1 is called a saddle joint. So it's pretty stable. So your head is sitting on C1. Well, actually, I have it here. You could see this joint right here. This joint is it's not a ball and socket, but it's pretty stable. So the C2 to C7 relatively stable, C0, C1 stable, and in between it is C1, C2, which is the most mobile joint in the body. C1, C2 is the most mobile joint in the body. So you can imagine if you're like this, what's going to happen? The looseness is going to happen at the most unstable segment, which is going to be C1, C2. So there's no disc between C1, C2. C1, C2 is totally held together pretty much by ligaments. You don't have big muscles holding C1, C2. So once those ligaments get lax, you're kind of screwed, actually. You're kind of screwed. There isn't an exercise you can do. There isn't a pill you can take. You have got to get it diagnosed. And the only way you can get it diagnosed is by a motion scan. The kind of motion scanning that we do is called digital motion X-ray. And we have a unique protocol that we do where I and my associates, we actually numb the muscles, because if you don't numb the muscles, those muscles can limit the motion, and then you don't actually see the instability. Next. Wow, look at this. So if you have forward head posture continuously, eventually you're going to get TMJ syndrome as the jaw is pulled forward. When you have a forward head posture, you're going to lose the cervical lordosis. Once you lose the cervical lordosis, eventually you're going to get cervical instability, and you're going to get degenerative disc disease. When you lose the cervical lordosis and the cervical spine curve reverses, then that means that the lower part of your spine is all bent down, So the only way you can look up is by hyperextension of C1, C2. So all the people out there who have occipital neuralgia, almost every case I've ever seen of occipital neuralgia, they have either malrotation of C2, they have ligament laxity of C1, C2, and you have a reversal of the cervical curve lower. So in other words, if the lower cervical curve is point down, the only way you can look up is if your C1, C2 hyperextends. Well, the C2 nerve root, which forms the occipital nerve, it gets squashed right here. It gets squashed between C1, C2. So it isn't just get prolotherapy to C1, C2. You got to get the curve normal. Once the lower curve has a normal orthotic curve, C1, C2 is going to be more straight, and then there's plenty of room for the C2 nerve root. Next. So the face down lifestyle leads to cervical ligament injury. The cervical curve changes. The weight of the head then is in front of the curve. This causes further ligament injury. Eventually, you're going to get destruction of the nervous system. And once the vagus nerve gets degenerated, which again we call cervical vagalopathy, degeneration of the vagus nerve. Once you have that, and your sympathetic system, your adrenaline system, is no longer inhibited by the vagus nerve, what are you going to have? So think about if the adrenaline system goes unchecked, you could get arrhythmias. You're going to get anxiety. You're going to get where your stomach is tied up in knots. You can't digest your food. You're going to get brain fog. You're going to get unbelievable fatigue. If you have unbelievable fatigue and nobody can figure out the cause, it's probably upper cervical instability. Next. So what happens is, this is just kind of a graphic. When you have ligament injury, eventually the ligament injury in the neck is going to cause disc degeneration. So the cause of disc degeneration is cervical instability. The treatment shouldn't be geared toward the disc like a surgical procedure. And you know why fusions aren't a good idea in most cases, because once you can't move that segment, like if this person in this graphic had C4, C5 fusion, and I saw a person the other day, they got a C4, C5 fusion. It was a disaster because it's very rare that you just have one level of instability. Most people, by the time they end up with fusion surgery or they come to a prolotherapist, they have like C1, C2, C2, C3, C3, C4, C4, C5 instability. So if you do fusion on just one of the segments, you're still going to have a myriad of symptoms because you have instability there. Also, once C4, C5 can't move anymore, the forces are going to go above and below C4, C5. So C3, C4, and C5, C6 are going to get degenerated and unstable. So it's not a good solution unless it's an emergency. Like if somebody's spinal cord's getting squashed, because of the instability, then you could consider getting a C4, C5 fusion. One of the reasons why we do digital motion X-rays isn't just to see if somebody's a candidate for prolotherapy. There are about once a year, maybe twice a year, we'll scan somebody and they actually do need surgery. So another reason to get it is to assess somebody if they actually do need surgery because the instability is so bad and their spinal cord is at risk. Next. Ben made this figure, so this is a great figure. This is C1. See, there's C1. This is C2. This is actually what it looks like. So you can see that the blood vessels go right by C1, C2, and there's a myriad of nerves that go right by C1, C2. The most important ones to me are the vagus nerve and the superior cervical sympathetic ganglion. Next. Okay. So this is C1, C2. This is the vagus nerve. So see how close the vagus nerve is to C1, C2. The brains of the vagus nerve, in other words, where is the nucleus of the vagus nerve? Where is the cell body of the vagus nerve? It's right here at the nodose ganglion, which sits right at C1. So when we talk about the parasympathetic nervous system, the parasympathetic nervous system is responsible for getting rid of inflammation in the body. So if you have inflammation all over your body, or you're on a medication like an anti-inflammatory, or you're on Remicade or Enbrel or some kind of tumor necrosis factor inhibitor, then you most likely have upper cervical instability because your vagus nerve is not doing what it should do, and you need a medication to get rid of the inflammation. So that's an important point. If you have inflammation all over your body and you need to take a medication, an anti-inflammatory, you probably have low vagal tone. And the low vagal tone is because the vagus nerve is getting injured right here at C1, C2. So if you want to get resolution of your systemic inflammation, like you have irritable bowel, or you've been diagnosed with leaky gut by a holistic provider, like your tight junctions in your digestive tract, they're separated, and you have all kinds of food sensitivities. You have chemical sensitivities, and nobody can seem to find the underlying cause of it. Well, the underlying cause could be vagus nerve degeneration, because it's the vagus nerve that innervates or connects to the enteric nervous system, which innervates your digestive tract. If you have constipation, what causes the bowels to contract? Well, it's actually the vagus nerve is what causes the bowels to contract. If you can't digest your food and you're bloated all the time, what causes the stomach to secrete stomach acid? It's the nerve input from the vagus nerve. If your gallbladder isn't working, what causes the gallbladder, the sphincter of Oddi, to open and close so bile goes into the digestive tract so you digest fats? That's through the vagus nerve. What causes your endocrine glands, all these endocrine glands, the thyroid, the adrenal gland, the pineal gland, all the endocrine glands, your ovaries to secrete hormones? That's through the vagus nerve. Or let's say you believe that you have sympathetic dominance, like you just can't relax. You have racing thoughts. You've been diagnosed with bipolar. You have anxiety. You have anxiety for no reason. You have a nice family, and you have anxiety and nobody can figure out why. Or you have arrhythmias. You have arrhythmias and nobody can figure out why. You have tremors. You have tremors, right? Tremors are, if somebody holds you up with a gun, wouldn't you start trembling? Well, all that trembling means that you have sympathetic dominance. So the superior cervical sympathetic ganglion, which basically controls in part the circulation to your brain and to the blood vessels that go to your brain, that ganglion sits right at C2. And guess what is the nerve ganglion that inhibits it? It's the nodose ganglion right here. So in other words, the vagus nerve input is basically inhibitory toward the sympathetic system. So if you don't have the vagus nerve input to the superior cervical sympathetic ganglion, though that sympathetic ganglion, that input can cause vasoconstriction to your eye. It can cause the ophthalmic artery to close off. You can get vasospasm, right? You've been diagnosed with a heart attack and you have vasospasm in your coronary artery and nobody can figure out why. You can get vasospasm to the blood vessels to your brain, right? You have dizziness. You have dizziness and nobody can figure out why. If you have dizziness when you're upright and you don't have dizziness when you lay in a bed, you probably have upper cervical instability, right? When you lay down in bed, your cervical ligaments aren't under tension, and then these ganglion aren't under stretch. So imagine if this C1 vertebrae was way over here. In other words, you have a forward head posture, and C1 was way over here. Would this not stretch your nodose ganglion of your vagus nerve, and would it not stretch your superior cervical sympathetic ganglion? So that's why the things are getting injured, and that's also why, to get better, it isn't just prolotherapy. You have to get what we call cervical curve correction. You got to correct your curve, and once you do that, once the curve is corrected and the tension is off of these nerve ganglion, then the autonomic nervous system function starts getting back to normal. Dizziness goes away, vision comes back, the swallowing difficulties stop, your vocal cords start functioning right, so your voice, we have a lot of female patients who say that they got hoarseness of their voice, the voice is getting deeper, they can't sing anymore. And again, the nerve supply to the vocal cords is the vagus nerve, right? So if you have anything related to swallowing, or you have voice changes, you're choking on your secretions, you probably have vagus nerve degeneration, vagus nerve injury. The vagus nerve only has 100,000 neurons, so it's not a lot of neurons. Your enteric nervous system has 100 million. So you can't afford to have vagus nerve neurons dying, but that's what's happening to everybody because of the cervical instability and the forward head posture. Next. Wow, look at this. In next month, I'm going to do a whole 2-hour webinar on the vagus nerve, so I hope you'll join me for that. We're going to go through an overview of the vagus nerve, but I'm going to go into great detail of how vagus nerve degeneration. We got amazing slides, and just know the vagus nerve has an unbelievable amount of regenerative properties. So when the vagus nerve gets degenerated, you get decreased stimulus to the endocrine glands, then you get infertility, you get male menopause, you get adrenal insufficiency. When the vagus nerve input to the spleen is not normal, you get immune system dysfunction, you can get Lyme disease, yeast infections. And if you research cancer and the autonomic nervous system, you'll see that it's probable that even cancer has autonomic nervous system etiology in some cases. You get bacterial overgrowth, leaky gut, you get colitis. If you have ulcerative colitis or Crohn's disease, you should get an assessment for upper cervical instability. If your liver or pancreas isn't working for no reason, if you have been diagnosed with diabetes and your normal weight, you probably have vagus nerve degeneration. If your vision comes and goes, like blurry vision comes and goes, you probably are getting vasospasms of your artery. We can test for that in the office here through transcranial Doppler. If it seems like your brainstem isn't working right, you have nausea continuously, your blood pressure control's bad, you have difficulty breathing, right? Almost like your breathing center isn't working right. You have arrhythmias. You have psychiatric disorders and nobody can figure out why. Most likely you have upper cervical instability and your vagus nerve input is not normal. Next. Your vagus tone is low. Just know joint instability anywhere in the body can cause various nerve injuries, a carpal tunnel syndrome. If you've been diagnosed with cranial cervical syndrome or cervical medullary compression syndrome, if you've been diagnosed with Chiari malformation, or you've been diagnosed with cerebellar tonsillectopia, it could be that just the tension on the spinal cord is causing your brainstem or your cerebellum to go through the foramen magnum. So that's what this is, the foramen magnum. So if you've been diagnosed with that, you should do an assessment for upper cervical instability. There are people that do need a craniectomy. They do need a C1, C2 fusion. But I would really encourage people before they get that, get an assessment for upper cervical instability. And if you have it, please get that resolved before you get surgery at a fusion at C1, C2 and a craniectomy. If you have any unusual neurologic symptoms, any weird kind of neurologic symptoms, you talk and then you get a really, really bad headache. You talk a lot and you get palpitations in your heart. Just something very unusual. You probably have upper cervical instability because your nervous system isn't working right. You have complex regional pain syndrome, or you've been diagnosed with small fiber neuropathy, you've been diagnosed with dysautonomia, you probably have upper cervical instability and should get an assessment by a digital motion X-ray. Next. Wow, this is another one. Okay, so this is the skull, this is C1, this is C2. So in our necks, you see that pulse, you can feel that pulse. That's the carotid artery. The vagus nerve, the glossopharyngeal nerve, and the spinal accessory nerve, they're all in that carotid sheath. That carotid sheath is within a few millimeters of C1, C2. So upper cervical instability can compress that sheath, and if you compress that sheath or stretch the sheath, you can get vagus nerve damage, and that can cause all these things. Eustachian tube dysfunction, meaning that the connection between your inner ear, your middle ear, and your throat, it doesn't work right. So you get ear fullness, you could have decreased hearing, you can have sensitivity to loud sounds, or in your eye, you could have sensitivity to light. So if you don't like bright lights, you probably have upper cervical instability. If you have cervical dystonia, like there's a certain muscle here that's contracting a lot, or you have torticollis, you've been diagnosed with trigeminal neuralgia, headaches nobody can figure out, you've had drop attacks, meaning I've had some of these things. So it's not just that I've been treating it for 27 years. I'm somebody who actually has had a drop attack. I was at a hotel, and just a drop attack is where you're doing something and all of a sudden you wake up on the ground and you're sweating and you're very scared and you have no idea how you got there. And the reason why people have drop attacks is normally because they're getting arterial ischemia, meaning that they have instability or they have cervical dysstructure where a certain motion decreases the blood supply to the brain. And that can be through the vertebral arteries or the carotid arteries. The reason why the tests at the hospital don't diagnose these is because often they do those tests with the person laying down. Where we do the tests, we do dynamic testing where we test your blood circulation when you're moving your neck. Next. So think about this. You might have allergy disorder, but it's actually a structural cause. It's caused by upper cervical instability. So there's structural anxiety, structural arrhythmia, structural autoimmune, structural depression, structural endocrinopathy, structural fatigue, structural brain fog, structural liver disease, structural irritable bowel, structural Crohn's disease, structural ulcerative colitis, structural Parkinson's. I'm not saying all the causes of Parkinson's is from upper cervical instability. I'm not saying all cancer is from a structural cause. I'm not saying a person has lupus and all the cause is structural, but it could be. It could be. So if I had any condition where all the doctors are doing is treating a symptom of it and the condition is getting worse, I would absolutely run. I wouldn't walk to a place like ours that does digital motion X-ray, and I would get a very good assessment for upper cervical instability. Because imagine if you have one of these conditions and it's actually treatable and curable, right? I was talking to Marion the other day. I'm one of the few doctors that has had patients take out spinal cord stimulators. So we have another patient that currently has the sciatica is all gone, and they're getting an assessment to get their spinal cord stimulator out. So you have chronic pain and you have a stimulator in, absolutely get an assessment for ligament laxity. Realize most of the nerve endings around a joint, even in the upper cervical area, are in the ligaments. So let me say that again. around your knee joint, around your C1, C2, around your atlantoaxial, all the joints of the body, most of the nerve endings are in the ligaments. Those nerve endings fire when they're under stretch. If the ligaments are tight, the nerve endings in the ligaments don't stretch. If you have ligament laxity, the nerve endings stretch. That's what causes the pain. When the nerve endings stretch, there's a reflex called the ligament muscular reflex, which is going to cause the muscles to tighten, and that's going to limit the motion. So if you have chronic muscle tightness, iliotibial band, your serratus anterior muscles, your sternocleidomastoid, any muscle that won't relax, you most likely have instability, and it's not going to relax until that instability is resolved. Next. Okay, yeah, we did this one already, so let's do the next one. Okay, we talked about, notice this MRI report, they don't even mention C1, C2. Like a lot of the MRI reports, they don't even look at C1, C2 because there's not a disc. So just because you had an MRI doesn't mean you don't have C1, C2 instability. Next. You can see some of the ligaments by high resolution MRIs, but you got to get an MRI with alar cuts. That's what it's called. So you get a 1.5 Tesla or 3 Tesla MRI, and you have to put on the form of alar cuts. Alar cuts are only 1 millimeter in width, where most MRIs, they're 4 millimeters. And the MRI signal, this white here, that shows that there's some swelling in the alar ligaments. Next. Okay, so we're just going to show you kind of a typical occipital neuralgia digital motion X-ray. See how it's rotated? The C2 vertebrae is rotated. So that would be the side where the person's occipital nerve, their C2 nerve is getting hit. So watch this. See when they do, they go to the side. They go to the side. See the overhang here? Yeah. So any kind of overhang, and then we measure that. Severe instability is when the overhang is over 3.5 millimeters. And then after prolotherapy, what happens is the overhang stops. So we tighten the capsular ligaments. Once we tighten the capsular ligaments, and just know digital motion X-ray can be used for the knee, for the wrist, for the neck, and we can do all the different views. Here we're just showing the open mouth view, and then the person's. Okay, next. We do the next one? Okay. So the C2 nerve goes into the occipital nerve. Why radio frequency and all those treatments don't work for nerve injuries is because they don't get at the underlying cause of the nerve injury. So the C2 nerve is compressed with upper cervical instability, and the C2 nerve goes into the occipital nerve, and that's why prolotherapy is so successful for occipital neuralgia, because it resolves the underlying cause of it. Next. So what happens is you should have a normal cervical curve. Once you get ligament laxity back here, the curve gets straight. Then the force on the posterior ligaments goes in the front. So in other words, see how I'm bent forward? I'm bent forward. That means the weight of the head is in front of the curve. That's going to stretch the ligaments in the back. Then you get a reversal of the curve, and this is what cervical destructure is. It's called an S-curve. See how this is a little bit like an S? So that's the progression of what happens. We normally see people when they already have an S-curve. So the treatment involves tightening of the cervical ligaments, and we do cervical realignment therapy, which involves various exercises and different kind of pillows and different things to get them the cervical curve. Next. So that's a normal curve. This is an abnormal curve. You can see the difference, right? Okay, next. Then this is Izzie. She's on maternity leave, just had a baby girl, so she's an amazing person. So, we do different kind of weights to get the cervical curve back. And then what we do is we X-ray people with the various weights on. So next. So this is a person. This is what the curve looked like. We put a 10-pound chest weight on. You could see it changed a little. Then we put a 10-pound chest weight and an 8-pound hood weight. It got better. See how the person got their cervical curve back with a 15-pound chest weight and a 10-pound hood weight. So the point is, we showed via X-ray that they got the cervical curve back with various weights, and we determined which weights. We sometimes have a person lay down on various pillows to see that the curve is good with various pillows. Sometimes we put them in different kinds of neck collars, neck braces, to see if the curve is good with the neck braces. Next. Okay. So this is kind of what the setup looks like in the office. So you can see I have X-ray guidance here. Here's our digital motion X-ray scanner. And you can see the person is very comfortable here. And I'm using X-ray guidance for the C1, C2 area. We normally see people every 4 to 6 weeks. And the normal amount of visits is anywhere from 3 to 8 visits. You know, on the first visit, after we scan them, I go over their scan and we can tell them how many visits most likely it's going to be. And then to give you an example of how quickly prolotherapy can work, this was a patient that we saw this week. So, well, I should say, saw the patient on Tuesday last week. Then they got their first visit on Thursday. This particular case, the person was losing weight. They had lost like 20 pounds in the last week because of the upper cervical instability. Their vagus nerve was shot. They had swallowing difficulty, dizziness. They were losing weight. They couldn't eat. Bloating of the stomach, liver not functioning good, blurry vision, terrible fatigue, brain fog, depression, anxiety. Then we did a very extensive procedure last Thursday, and the family agreed to stay here. They were going to stay here in the Fort Myers area because it was getting critical. Because if the vagus nerve really isn't working properly in doing normal input to the digestive tract shuts down. So they agreed to stay here until the person could eat. Well, when I saw them on Monday, so that was only 2 days ago, you didn't even think it was the same person. Like all my staff, like you couldn't, they had color in their face, they were smiling. So they were in a collar, but after the treatment on Thursday, they had normal nutrition basically Friday, Saturday, Sunday. So I cleared them to go home. So there are times where right away somebody feels better. Now, it is going to take them they'll probably end up getting 6 visits or so. So it's going to be a lot of visits to resolve the thing. But it isn't like you have to wait months and months to feel better. Most people feel better right away. Next. Oh, so remember when I said hyperextension? You could see this is really angled. And it's angled because you have a reversal of the curve below. And the C2 nerve that goes into the occipital nerve, it's right here. And it's actually that C2 nerve, the irritation of that causes most headaches. So if you have headaches or you have sensitivity to touch on your scalp here, and you have headaches and nobody knows the cause, it's probably because of compression of that C2 nerve right there. So the treatment is resolution of the curve here, resolution of the cervical instability, and to get the curve back to normal. And then once that happens, the headaches go away, and often they go away permanently. Next. So these are some of the spots that we inject with prolotherapy. This is the capsular ligaments here. These are the capsular ligaments here. So there's a shot. Oh, I'm sorry. Can you go back? I'm sorry, I clicked something. Oh, okay. So there's a shot there, shot there, shot there, shot there, shot there, shot there. So it's a lot of shots, and but it works very, very good. And we numb the area. We have some of the patients, they do take some medications to get them through the treatment. We do have laughing gas, and for really big cases, we do have a nurse anesthetist that can come in and give somebody conscious sedation. Next. So this is what prolotherapy does. When you have a degenerated ligament or an injured ligament, there's a deficiency of cells. To show you how forgotten ligaments are, look at this term ligamentosis. I've never had one patient ever come in where a doctor diagnosed them with ligamentosis. So think of that. Like, you know what I mean? Like, it's almost like the surgeons and the regular doctors, they totally forgot about ligaments. I think ligaments are the Rodney Dangerfields. Like, I get no respect. Like ligaments get no respect. Do you know I've had almost nobody ever come in with the diagnosis of joint instability, and we diagnose joint instability on almost everybody because we do objective testing. We do either motion scanning with an ultrasound, like I do that on a knee, on an ankle, and then we do digital motion Xray, like on the neck, on the wrist, and we show the excessive movements of the bone. Ligamentosis is when fibroblastic cells die, right? They die. That's what the word degeneration means, is cell death or tissue death. So when we talk about cartilage deterioration or disc deterioration or tendinosis, it basically means that cells have died, right? When we talk about an organ that's having trouble, like you got liver disease, it means liver cells are dying. If your stomach isn't working, its stomach cells are dying. Well, why are they dying? And then when the cells die, when the fibroblastic cells die, eventually those cells can't make the ligaments. They can't make the collagen. Once they can't make the collagen, you can almost see here where there's like scarring, like scar tissue. When we do prolotherapy, there's a massive influx of fibroblastic cells and other cells. So that's why Dr. Hackett, when he did his animal research back in the 50s, he found under the microscope that there was fibroblastic proliferation. That's why he called it prolotherapy. And the goal is to get the ligaments thicker, stronger, healthier. Once the ligaments can withstand the forces on them to control joint motion, and the C1, C2, the knee, the ankle is stable, wow, it's amazing all the things that get better. Next. So the upper cervical spine, there's actually 4 synovial joints, 2 at the C1 dens transverse ligament, 2 at C1, C2. When you have good posture, 2/3 of the force is on the facet joints. So with my model again, that's the facet joint. This is the facet joint. So when you have good posture, the force is on the facet joint. As you can see here, if I go like this, see how the facet joint opens up, and the force goes on the disc. Cervical lordosis is present by 9.5 weeks of gestation. So the fetuses have a cervical curve. And then when kids are crawling and they're looking up, their cervical curve gets bigger. It gets larger. When kids are walking, they're looking up to adults. So can you imagine the kids are supposed to get a bigger and bigger cervical curve, lordotic curve by looking up. And what are your children, your neighbor's children, your friend's children? They're looking down at tablets. So guess what's happening? Those kids they don't develop. They have stomach problems. Their stomach shuts down. They have stomach cramping. They have crazy anxiety, right? They yell. They have poor problem-solving ability. They have muscle tension disorders. They have migraine headaches. It's because you got them in front of tablets. Get rid of all the tablets. Get rid of all the cell phones for your kids. Otherwise, you're going to end up. I recently consulted on 2 children that are under the age of 4. And they have horrific swallowing difficulties, chemical sensitivities. You can't touch them. They're screaming because their vagus nerves aren't working. 75% of cervical lordosis occurs at the C1, C2 level. So if you have instability at C1, C2, the curve's going to be bad, and you're going to end up having a lot of autonomic nervous system problems. Next. Right? This is terrible. Please get rid of the cell phones and the tablets for your children. The children got to be looking up. Even with your computer system, you have to be looking up. Get your computers up, up, up. We got to be looking up. The more you look down, the more you're going to have cervical ligament laxity, and the more likely you're going to have deterioration of your nervous system. You're going to have a host of medical problems, and you're going to end up needing a lot of prolotherapy. So please start looking up, looking up, looking up. Stop looking down. Next. So this is what happens. You get ligament laxity here when you flex, and when you look up, the ligaments are tight. Next. Okay, this is interesting. So the no motion, the axis of the no motion is C1, C2. So after prolotherapy, we limit the no motion for, again, a month or 6 weeks. The cell phone, when you're looking down, the axis of that is C4, C5. So the two most common instabilities that we see when we do digital motion X-rays is C1, C2 instability and C4, C5 instability. So after prolotherapy, we have to limit the motions that give the instability to allow the ligaments to tighten. You have to think of prolotherapy as putting glue in there, and we're going to glue the areas together, but you got to keep them tight. Next. So here are key points about the C1, C2 joint. I said it's the most mobile joint in the body. It allows rotational movement. So if you think about the neck is to point the head in the right direction so you can do everything you want. It's the ligaments, it's the nerve sensors in the ligaments of the neck that tell your head basically where it is in 3D space. So if you feel like your head's going to fall off, or your balance is just terrible, or your fatigue's terrible and you have to lay down, that's a sign that you have upper cervical instability. The flatness of the joint surfaces, that's what allows the motion at C1, C2, but that also is why the C1, C2 gets unstable. The atlas is C1, the axis is C2. Many ligaments and muscles attached to C2. So I look at the position of C2 is the most important position of any vertebrae, is the position of C2. Next. So the axis, I think the axis, not the atlas. I believe C2 is the most important bone in the human body. It gets no respect. Rodney Dangerfield, I get no respect, no respect. The atlantoaxial joint is the most mobile of the spine. Remember I said the superior cervical ganglion, that sits at C2. It's a one-of-a-kind bone because it has this dens, and it has this really stout, this really strong, short, stubby spinous process where there's so many muscles that attach there. There's over 20 structures that attach to and stabilize and move the head that attach at the axis. So your axis, C2, it has to be in the right position, and it has to be very, very stable. Next. Look, this is actually it. This is C2. You can see all the muscles. So if you have tension like right here, tension, like it's always tight or it always hurts or you always have a headache there, most likely you have instability at C1, C2. Next. This says a lot. See, when you have malrotation of C2, so if you have malrotation of C2, on one side you could get migraine headaches, fullness in one ear, ringing in one ear, blurriness of vision in one eye, tearing of one eye, choking sensation. But in the other side, you could have other symptoms, like you could have occipital neuralgia. So I'm going to share with you a couple things that you can look at in your own life. Like you can shine a light in your eye to see if one pupil is more dilated than the other. That's a sign that you probably have upper cervical instability. And if your uvula is deviated. If your uvula is deviated to one side, it means the muscle on the opposite side that raises the uvula, that raises your uvula, it's not working, and that muscle, the levator, villi palatini muscle, is innervated by the vagus nerve. So look at all these symptoms, short temper, anxiety, lightheadedness, swimming sensation, increased heart rate. If your heart rate is higher than normal, or you're having blood pressure fluctuations, or any kind of pressure hurts, you probably have either malrotation of C1 or C2, or you have instability. Next. Look at all this. If you have cervical destructure, so I call Hauser's disease destruction of the cervical spine causing destruction of the nervous system. It's kind of easy to understand. If you have destruction of your cervical spine, you lost the supporting structures of the cervical spine, the ligaments. It's going to ultimately destroy your autonomic nervous system. Once you destroy the electrical grid of the body, you're going to get an unlimited amounts of horrific diseases. Again, if you have a medical condition, a medical symptom, and nobody has figured out why, you have got to get an assessment for upper cervical instability because you probably have it. Next. So when a nerve is functioning normally, then, like for instance, the vagus nerve, if the vagus nerve is functioning normally, a person is calm. The organs, there's the normal amount of hormones secreted. There's not pain. When you start getting inflammation around a nerve, you often get pain. That's normally the first thing, but eventually you're going to get degeneration of the nerve. So the vagus nerve, it means that neurons start dying. Next. That's called neuropathy. So this is a great figure. Basically, when you have the vagus nerve starts getting degenerated, it's going to inhibit the superior cervical sympathetic ganglion, and then that's going to cause decreased input to this artery, and that artery is going to increase the circulation to the vagus nerve. So that's what's supposed to happen, but what happens is if the vagus nerve gets too degenerated, you don't inhibit the sympathetic system, so then this artery goes into vasospasm, and then it decreases the blood supply not just to the vagus nerve but also to the brain. Next. And there's lots of people who think there's something wrong. They got brain fog, they can't concentrate, they're not themselves. Their personality changes. If you have a personality change for no reason, you're irritable, you're not yourself, you're not peaceful, where you normally would be a peaceful, calm person, you probably have upper cervical instability. Next. See, the parasympathetic system, which the vagus nerve is basically 75-80% of the parasympathetic system, it has to do with healing, regeneration, nourishment of the body. It builds up the body. It innervates all the intestines. It innervates the endocrine glands, the pancreas. It activates digestion. It gives you calmness, contentment, relaxation. It helps you sleep. It like, for instance, when you hold hands of somebody you love, or you pet your cat or your dog and you feel calm, that's increasing your vagal tone. Now, the sympathetic system, that's what defends the body under attack. So you can live without your sympathetic system. So if you have an animal and you destroy the sympathetic system, but the animal is in a very peaceful environment, they can live fine. But once they get a stressor, they die. So the sympathetic system is what helps you handle stress. So you need your sympathetic system. The problem is you don't want to have your body under stress 24/7. So if your parasympathetic is not working because you have C1, C2 instability, stretching, destroying, compressing the vagus nerve, then you get sympathetic dominance. So it's as if you're under stress all the time. So then you feel sad, you feel guilt, you feel aggressiveness, you feel worry, you have excessive thinking. Next. This just shows that the sympathetic system is involved with stressors, and the vagus nerve is involved with restoring health. So if your health is not getting restored, if your health is not getting restored, you probably have your vagus nerve isn't working correctly. So you need to get assessment for upper cervical instability. Any of these symptoms, anxiety for no reason, blurriness of vision, one part of the face is hot and the other one is not, you have oversensitivity to light, you have restless legs, the sound of your own voice is too loud, you have tenderness to touch, you have hoarseness, like I have right now, lightheadedness, all those things can be from upper cervical instability. Next. Low parasympathetic activity, scientific studies that show that it precedes death, it precedes cancer, it precedes rheumatoid arthritis. You have a greater risk of getting diseases, including cancer, if you have low vagal tone. If you have low vagal tone, you have a pro-inflammatory state. You have a pro-inflammatory state, and inflammation goes uncontrolled around the body. So you have to get on anti-inflammatories, but a better approach would be to resolve the vagopathy and get your cervical spine stabilized with prolotherapy. Next. The way we monitor vagal tone is through heart rate variability. I'm going to talk about this at the next talk next month in more detail, but basically you guys can research heart rate variability. What it is when you take a deep breath in, what's supposed to happen is your heart rate speeds up a little bit, and when you breathe out, your heart rate slows a little bit. So when your vagal tone is high, your vagus nerve is functioning good, you have a high heart rate variability. Next. Then this is, we have a setup here. So we monitor, we have different monitors that we put on the patient to monitor not just their heart rate variability, but the components of heart rate variability. And then we teach people how to improve their vagal tone and how to increase their heart rate variability. Next. The music you listen to, it could be you're listening to music because it makes you feel better, but it could be causing you low vagal tone. So you can put a heart rate variability monitor on your finger, download an app, put various music on, and you might be surprised that the various music you listen to, it's not good. When you put on Beethoven or you put on Pachelbel, then the heart rate variability often goes up. Next. So you need to have good vagal tone to be peaceful, to heal good, to have inflammation under control, to have good balance, to not have pain, to be able to concentrate. Next. This is interesting. Signs and symptoms of pending autonomic collapse. So if you have where you're getting more and more fatigue, you're starting to be lightheaded, you're starting to faint, you have low blood pressure, you can't control your temperature, your pupils are dilated, your uvula is deviated, your fatigue is worse and worse and worse, then you better run, not walk, to somebody who can assess your upper cervical instability and then start receiving prolotherapy if instability is found. Next. Okay, so let's see this. This is interesting. If you watch this, and you can do this at home, just get in a dark room and then just see how your pupils are supposed to constrict. Watch this. Okay, watch this. See how the light's on and then it starts to dilate some more? You'll see this on this one. Watch this. See how it's dilated? See how that's dilated? See how that's dilated? It's not constricting the light. So that's a sign that you have sympathetic dominance and you have low vagal tone. You have low vagal tone. So the pupils are supposed to constrict. So you might find that one side, one eye, it stays dilated and the other one constricts. So on this side, you have a problem with your vagus nerve and you have too much sympathetic tone on that side. Let's go to the next. Okay, this is kind of my favorite. I love deviated uvulas. So watch this. See how the uvula right here, it's deviated to her right. So that means the muscle right here is not working. So on the left side here, the person has vagus nerve degeneration. We're not going to show it here, but we'll show it next month of how we measure vagus nerves. We can actually measure the diameter of the vagus nerve. And if you research vagus nerve degeneration, you'll see disorders like Parkinson's. One of the physiologic things that are found with Parkinson's is that the vagus nerve is degenerated, but you can see where the uvula is deviated to the right. Next. Okay, so we see that forward head posture. It's going to stretch the spinal cord and it can stretch the vagus nerve. Next. And then you can also get blockage of cerebral spinal fluid. So if you feel like you have head pressure, like nothing's helping the head pressure. Like the head is always tight, it's pressure. You probably have increased intracranial pressure because the instability at C1, C2 is blocking cerebral spinal fluid flow. Next. So we can see here, so if your C1, C2 is moving too much, this space where the spinal cord is going to get narrowed, and the spinal cord is surrounded by cerebral spinal fluid. Next. This is a scan. You can get a cine phase contrast MRI. So this is from Dr. Rosa. You can get a cine phase contrast MRI, which can show that cerebral spinal fluid flow is blocked. What he does is he does a certain type of adjustment, with a specific device, and then he can show that the flow is restored after the C1 is adjusted. And when the flow gets blocked again, or it's clear that the person has instability, he'll refer them then for prolotherapy. Next. So signs and symptoms of increased intracranial pressure. So what we do is measure the optic nerve. So we have people who have large optic nerves. If the optic nerve diameter is greater than 5 millimeters on ultrasound, that's a sign that the person has increased intracranial pressure. The increased intracranial pressure, and this is by high resolution ultrasound, it can cause double vision, blurry vision, inability to concentrate, head pressure, flashing of light. And if you have somebody who has a weird visual symptom, like things are wavy, or you see an object, you look away, and then you still see the object, you probably have swelling of your optic nerve. And the way you can document that is with high resolution ultrasound. So we actually do an ultrasound of your eye. Next. Lots of people have had tests for vertebral basilar insufficiency, arterial ischemia, and the tests come back normal because the people are getting tested while they're laying down. So I think the arterial ischemia from atlantoaxial instability is so much underappreciated, underdiagnosed. In almost 100% of our patients that we see with drop attacks, they have arterial ischemia. And arterial ischemia can be the carotid or the vertebral artery. And just realize those blood vessels are within 2 or 3 millimeters of the cervical vertebrae. Next. So this is an ultrasound scan, the carotid sheath. The vagus nerve is in the carotid sheath. The carotid artery, this is the internal jugular vein, and this is the cervical vertebrae, and see it's only 2.8 millimeters. So clearly, lots of the instabilities we document are on the order of 3, 4, 5, 6 millimeters. Next. So you could see that the vertebral artery is within the cervical vertebrae. So obviously, if you have excessive movement of the C1, C2 vertebrae, it can block this artery. Next. And this is the carotid artery. So the carotid artery goes to the anterior 2/3, 3/4 of the brain. The vertebral artery goes to the brainstem, the spinal cord, and it goes to the posterior 20% to 33% of the brain. Next. Okay, so here, this is an interesting scan. So this is a patient that came over from Europe, and he had, so here, see how we're watching, this is the waveform. You could see me, I have the scanner on him. See right here, see the wave. See, now it stops. See how the blood flow stops when he moves? Then when he goes forward, the blood flow, the waveforms start again. Right? So we're looking at, the brain, the circulation to the brain, and we're seeing that here. Let's just look at this again. So I'm looking at the vertebral artery. So I'm looking at the vertebral artery. See the waveforms? He has normal circulation. See the waveforms? Then all he does, look at this, he just moves up a little. He's just going to look up a little. Look up a little. He's looking up a little. See, look at this. All of a sudden it stops, it stops, it stops. Then he looks down again, then it starts again. I mean, you can't get more objective than that. Like, in other words, his cervical destructure, his poor cervical spine, along with the instability, is causing him to have arterial ischemia. He had it not only in his vertebral basilar system, but he also had it in his carotid. If you've been diagnosed with some plaque in your carotid artery, but they said it was non-significant, but you actually had like a stroke or you had a transient ischemic attack where you got weakness on one side of the body, you probably have dynamic stenosis. It means that you don't have significant stenosis when you're just laying down. But when you move your neck in a certain position, you probably have stenosis. And the only way you can document that is by looking at blood flow while you move your neck. Next. Okay, next. You know, and this is kind of what it looks like. It's us. We have different scanners. So this is me with a patient I'm looking at. You can see the blood vessels here. Next. And then this is, this is kind of what it looks like. We can look at the various blood vessels. We can look at the arteries in the circle of Willis, middle cerebral, anterior cerebral, vertebral, basilar. We can look at the external carotid, internal carotid. We can check for plaque. But mostly we're looking for, is there blockage of the artery when a person moves? And man, when we find this, it's definitive. So for the first time, the person has an explanation of why they're dizzy, why they have ringing in the ears, why they have brain fog, why they feel terrible, why their personality changes, why even some days they feel decent or kind of better, because on those days they don't have arterial ischemia. They have good blood flow to their head. But if you have a day where you're moving your head a lot or you're working on the computer, you could have been decreasing your blood supply, many, many times during the day. Next. Okay, so transcranial Doppler. Okay, so here, this is actually what it looks like. So this is Christina, this is a patient. So she's looking at, so there's different parts of the bone in the skull that the ultrasound wave goes through. So we locate the blood vessels and then we have them move different ways and to see if the blood flow stops or changes. So that we just call that dynamic transcranial Doppler or dynamic extracranial Doppler. So that's kind of the process that we do. It's a very extensive process, takes a long, long time, but wow, is it revolutionary for our patients, because for the first time, they actually have the cause of why they feel terrible. Their arterial supply is going down in the brain, their vagus nerve function is low, and it's all because of the destruction of the cervical spine from ligament injury. Next. Okay, wow, we can see. So if a person has a headache, this is what a headache looks like under transcranial Doppler. See the one side? You don't see the blood vessels, but see all these blood vessels are dilated. So that's what a headache is dilation of blood vessels. So you can actually see a headache in action. This person was having a right-sided headache. And that's what it looks like. And then obviously we could treat them and then the headache goes away and we could see that the blood circulation gets back to normal instead of dilated. So if you're on Imitrex all the time, the cause of your migraine headaches or your vascular headaches, it's most likely upper cervical instability. So if you want to get cured of the problem, my wife, Marion, says her migraine headache started the day that she married me. Now, we know that couldn't possibly be true, but the very first area she got treated was her neck, and for her to get a migraine headache now, she has to be dehydrated. She has to be under a lot of stress. She has to be working on the computer a lot. Like, there's about 20 things that have to happen, but otherwise, for the last 25 years, she hasn't had migraine headaches. Next. So cervical instability can cause trigeminal neuralgia, block of cerebral spinal fluid flow, vagus nerve compression, brainstem compression, autonomic nervous system dysfunction. Oh, this is interesting. If you look at this, I would ask you to study this slide because this shows, it's interesting, how cervical instability can cause every single kind of headache. It can cause cluster headache, migraine headache, nerve tension headache, muscle tension headache, motion headache, nausea headache, exhaustion headache, allergy headache. So it's unbelievable. So again, by Occam's razor, are there really 100 different kind of headaches, or a person, they have 5 different kind of headaches? Or do they probably have one etiology, which is cervical instability, which is the explanation of why one day they have a muscle tension headache, the next day they have a vascular headache, the next day they have occipital neuralgia. So it's probably because they have cervical instability. Okay, next. If you research headaches, most people believe headaches occur through the trigeminal cervical nucleus. That's a part of the spinal cord and brainstem that goes all the way down to C3. So if a person has instability at C1, C2, or C2, C3, that can activate that nucleus, and then they'll get vascular headaches. So vascular headaches are almost all because of this, and you can absolutely get cured of migraine headaches. Next. Wow, look at this. So here's the trigeminal nerve. Then this nerve then goes, the tract goes all the way down to C3. So if you have instability at C1, C2, it can activate this ganglion, and you can get trigeminal neuralgia, facial pain, and you can get sensitivity to sound. You can get terrible headaches. Next. And then, of course, ligaments themselves can give you headaches. So these are the referral patterns of the various ligaments. So ligament injury of the neck can give you a frontal headache. So if you got like a headache, like right here, and it doesn't go away, it's probably from ligament laxity in the upper cervical spine. Next. People with Ehlers-Danlos syndrome. So Ehlers-Danlos syndrome is a genetic disorder where there's looseness in pretty much all the joints of the body. And Ehlers-Danlos syndrome, the most disabling part of it, I think, is the upper cervical instability. And the way to document the upper cervical instability is with digital motion Xray. And then if you treat the upper cervical instability and get stabilized, all these manifestations of Ehlers-Danlos syndrome, including tinnitus, mast cell activation, gastrointestinal disorders, trigeminal neuralgia, chronic fatigue, drop attacks, cerebellar tonsillar ectopia, they can all be improved and often helped and cured with prolotherapy. Next. C1, C2 instability can give you low blood pressure. It can give you diminished autonomic nervous system malfunction. It can cause eustachian tube dysfunction. So if you've ever been diagnosed with Meniere's disease and you got fullness in your ear, and like your inner ear swells, or you get inner ear, middle ear infections, you probably have upper cervical instability, and all these things can give you dizziness. If you said, what are the most common symptoms of upper cervical instability? Most of the studies would say number 1 is neck pain and neck tension, especially tightness of the muscles up here. Number 2 is headaches, especially migraine headaches. But a real close third would be dizziness, because there's many reasons why upper cervical instability causes dizziness, but your reflexes of vision aren't quite right. Your inner ear is off because the pressure of your inner ear is not quite right because the muscles that open up the eustachian tube to drain the inner ear, they don't open quite right. Why you get hoarseness or your singing voice changes is because the nerves that open the vocal cords, those are from the vagus nerve. So any of those symptoms that a person has and it's not getting resolved or it's getting worse, please get an assessment for cervical instability next. This just shows high pressure in the ear because the eustachian tube is closed. The levator veli palatini muscle, that's the vagus nerve. That's innervated by the vagus nerve. Next. And again, if somebody has severe neurologic problems, like they have complete transection of, of the transverse ligament, or their spinal cord is getting crushed, they may need cervical spinal fusion. But most of the autonomic nervous system dysautonomias, the pinched nerves, the migraine headaches, the balance issues, tinnitus, ringing in the ears, they do really well with prolotherapy. Next. Like, think about it. Would you rather see somebody like me, granted a little bit goofy glasses, or would you rather see these people and get a cervical fusion? Like, don't they look kind of scary? Next. This was a referral from Mexico. As a prolotherapist referred me a case. We did a digital motion X-ray, and they had complete transection of their transverse ligament. So we sent them for emergency C1, C2 fusion. So here's the fusion here. So this is their atlantodens interval here was greater than 10. So there definitely are times where I send people right away for cervical fusion because they have a life-threatening illness, and that's what this person had. Next. This is prolotherapy to the C1, C2. Next. We've done various studies, so I refer people to caringmedical.com. My email address is drhauser@caringmedical.com. So if you have any questions after this webinar. And we have various studies, not just on the neck, but also we've done various case reports and studies on low back pain, neck pain, knee pain, ankle pain. Next. Glenoid labrum tears, 69% cure rate. Hip labral tears, 54% cure rate. Meniscal tears, 27 out of 28 didn't need surgery. Advanced osteoarthritis, 24 out of 24 no surgery. That was with bone marrow. Chondromalacia patella, the pain level went to that. Cervical instability study we followed them for 2 years, 21 cases. The pain levels went from 7.7 to 1.9. In 2007, just for fun, I followed the first 34 patients that came to me because they didn't want to get surgery. Like a doctor had already said they need surgery. And we followed them 10 months after the prolotherapy, and 3 out of the 34 needed surgery. But so if you've been told you need neck surgery or any other surgery like a joint replacement, I'd really encourage you first, before you sign up for surgery, to get an assessment by an experienced prolotherapist. Next. We ran a charity clinic in rural Illinois. In that charity clinic, when the charity clinic ended in 2005, we started in 1994. We got data on 709 of the patients. And in this study, 0 pain or no pain was actually a pain level of a 1. So we're the person gathering the data, we don't know how that happened. But basically, the cure rate, which we called 90% pain relief for all the different areas, was 72%. So the cure rate, when Hackett did his data on almost 2,000 patients, his cure rate was 85%. And Dr. Hemwall, his cure rate on 2008 patients, that was 75%. And our cure rate in our charity clinic was 72%. Next. So there's lots of ways you can increase your vagal tone. So if you have dysautonomia or you have a lot of symptoms, what I would recommend that you do is see if your uvula is deviated, see if your pupils, they don't constrict with light. That would be signs that you have sympathetic dominance, so you need to increase your vagal tone. I'd get an HRV monitor. You just go on Google, and there's lots of different companies that sell HRV monitors. They only run like $150. Then you start working on ways that increase your vagal tone, which increase your HRV. Even cancer, when you have a high HRV, your survival from cancer is greater. So ways to increase your vagal tone is activities that calm you down, like listening to calming music, sitting quietly, slowing your breathing rate down. It turns out the breathing rate that increases the vagus tone maximally is in most people anywhere from 6 to 8 breaths per minute. And most of us breathe 10 to 15 times a minute. So we all got to try to decrease our breathing rate down. Obviously, laughter, we all know, we all feel better with laughter. Pets, prayer, strong belief system, uplifting, encouraging friends. Next. So if you have any questions, and I appreciate everybody listening, so thank you so much. I hope this is helpful, and if you think like you have upper cervical instability, please get an assessment. And if you want me to answer any questions, or you have any questions about this talk, please email me at drhauser@caringmedical.com. I'm now going to take some questions. So Ben.
Yes, Dr. Hauser. One of our viewers wants to know, do you start to do the weights?
Yeah, do you start to do the weights like
for curve correction right away?
Right away. Sometimes we do. Sometimes people's instability is so severe that you have to wait on the curve correction. And just know, I see some severe cases. Just know I do have one case where it was even a severe transverse ligament injury where the client lived here for 3 months and they didn't want to get surgery. And then by the end of 3 months, they were doing great. In other words, there are some cases where we actually have to treat them every 2 weeks, every week. In other words, some people come where, like I gave you the case example of the person that was losing 20 pounds in the last month. Like she can't, she wasn't big, like she can't lose any more weight. So the point is, if the curve is terrible, the curve's terrible, and it's causing the stretching of the ligaments, so we might start the curve correction right away, which involves, in most people, putting your computer up. Like you got to put your computer up. You got to stop the face down lifestyle. You may have to wear a collar. You may have to lay in bed on a specific kind of pillow that gives your cervical curve. And then you may have to wear the weights. Yeah, you may have to wear the weights.
Do you have to do the weights forever?
Yeah, that's a great question. Do you have to do the weights forever? I guess my question would be, do you have to exercise forever? Like, all of us, let's be honest, we live in the computer age. And if we don't do something to decrease the tension on our nervous system, so maybe one of the take-home points of this talk is your nervous system is under assault. And if you don't do something about it, your nervous system is going to get more and more sympathetic dominant. Your vagus nerve is going to get more and more degenerated, and you are going to end up with a horrific disease. Like it absolutely is going to happen. And you're going to end up with anxiety. You're going to end up with fatigue. You're going to end up more and more disabled. So all of us need to be cognizant of keeping our cervical curve, and that has to do with raising our computer screen, stop with the face down lifestyle, or otherwise you're going to end up spending your hard-earned money getting prolotherapy. And I want you to be healthy, and I want you to be a blessing to your friends, to your family, to your children, to your mother. Like that's what we all should be doing. We shouldn't be in doctors' offices. So if I take on a case, it's because I believe that the case can get cured. So just know we go for the cure. So people come to Caring Medical, to the Hauser Neck Center to get cured of their condition. That's why a person has to be all in. You have to be all in. So we do an assessment. Sometimes we do the autonomic nervous system testing. Sometimes we do the arterial testing. We do the digital motion X-ray. And then we come up with a plan that we all agree on. And then if a person goes all in and they don't stretch the ligaments while they're getting treated, the ligaments are going to tighten and they're going to get back to their life. Okay, next question.
Good question. Do you need to stop migraine meds before starting?
Okay. Do you need to stop migraine meds? I actually don't like people to stop the meds because then again, if you feel worse, if you feel like, say I do prolotherapy and we monkeyed with the person's meds and the person felt the migraine headaches got worse, we don't know, is it from the prolotherapy, from the malrotation, is it from the meds? So I initially don't like people to change their meds, like just stay on the meds. If somebody's on a lot of anti-inflammatories, we might decrease those. But now you just come here, you're on your meds. How we do it is a person makes an appointment. So they contact us, they make an appointment. We take the history, we take a lot of the history over the phone. So before I get a case, one of my staff has actually talked to the person like a week or two before they come. In large measure, I want to make sure that they're a candidate. I'd hate to have somebody from Colorado fly in here and they're not a candidate for prolotherapy. So we definitely get a full history. So then normally though, we just have you on your meds and we talk about the meds. But we definitely are successful at getting people off of narcotics, off of anti-inflammatories. Sometimes, of course, I didn't even say this. When you have a lot of chronic pain and cervical instability, normally your hormone levels are low. So in many people, and I didn't do a slide of this, but we probably should at the next talk do a slide. It's unbelievable how low people's hormones are. They're almost zero. So in other words, often I'll check the hormones, DHEA, pregnenolone, testosterone, the anabolic hormones, because those are the hormones you need to heal better, to have a lot of fibroblastic proliferation. So sometimes we have to get people on a healthier diet and we have to get them on natural hormone replacement to heal good from the prolotherapy. So it's really that. What can a person do so they heal optimally with prolotherapy?
Here's a very specific question. Can C1 instability cause Chiari malformation?
Yeah, can C1 instability cause Chiari malformation? Really good question. And I'm saying there are cases where the cerebellar tonsillars block the foramen magnum. So in other words, parts of the brain go in this hole where you actually do need a craniectomy. But very seldom will a doctor just do that operation. It's normally combined with a C1, C2 fusion. So that kind of is intriguing, isn't it? Like, think about that. They don't just give the brain more room by taking out a small section. So they might take out a small section of the cranium called a craniectomy, but they do a C1, C2 fusion. So remember I said that when you have a reversal of your curve, that the spinal cord thus is stretched 1 to 3 millimeters. So what it means is there's this massive pressure on the spinal cord pulling down because of gravity. So thus your brain structures, because of that force, can then drop down. So in my opinion, some of the causes of Chiari malformation, I'm not talking about Chiari that you're born with, I'm talking about that have developed later in life, and cerebellar tonsillar ectopia can be from cervical instability. So before I would recommend somebody get Chiari surgery, I think you should get an assessment by a skilled prolotherapist and get evaluated for cervical instability because and just know I definitely have referred people for Chiari surgery. I definitely have had patients get a C1, C2 fusion. And I would say that overall, 50% of the people I've referred, I still have had to see them afterwards for prolotherapy. So 50% of the people, even I've sent to surgery, they still had symptoms from other cervical instabilities.
That leads us to our next question. If you've already had fusion surgery, can you still get prolo?
Just know when we do a digital motion X-ray in people who have pain after a disc replacement or after a fusion or even after a joint replacement, like even a knee joint replacement, what we almost always find is instability. So you have to realize when they put those disc replacements in there, they have to spread open the cervical vertebrae, and sometimes those ligaments don't tighten. Or if you have a friend who had a knee replacement or a hip replacement and they're still having problems, you have to realize when they go in there, they have to spread the ligaments apart to put the replacement. So every case of, pain after fusion or pain after disc replacement or pain after a joint replacement, they always have instability. And like I said, fusion, what's good about fusion, it does stabilize the area. So if you just have one area of instability and they fuse it, that could be curative. But often what happens is the forces then go to the level above and below, and then those get unstable. So we document that with digital motion X-ray, and those are the segments that we do prolotherapy on, but then the pain goes away.
Okay, do you have to get Prolo over the years to maintain?
Yeah, most people, once we're done with prolotherapy, they don't have to get more prolotherapy. I think because of cell phones, this is just me, I think in my future, there probably is going to be people that have to come once or twice a year, because let's be honest, even once they get stabilized, the cell phone is so tempting, right? And let's be honest, you're going to bend down, you're going to bend down. So what I would recommend is you guys should check out prism glasses. So prism glasses, your neck is up and the glasses go down. You know, they have a mirror here and it faces down. So I think if more and more of us use prism glasses, you know, then you won't be looking down. So if you, like the neck, think about this. We don't have big muscles in the neck. So I think the human neck was meant to look up and it wasn't meant to look down. This is just me. I just don't think God designed, and I believe in God, God designed the human neck to be 10 hours a day, 12 hours a day looking down. And if you just do that, if I do prolotherapy on you and you look down, you look down, you look down, the ligaments are going to get lax and you're going to need touch-up treatments, which is good for me, bad for you.
All right, this last one's a two-parter. Do all Prolo doctors practice the same way you do? And do they have these methods to measure the things you discussed?
Yeah, the question is, do all prolotherapy doctors have the same devices that we have to measure the blood flow, to measure the joint instability, and do they use the same technique? What I always say is, what I do has been developed over 27 years in something like 75,000 to 80,000 prolotherapy sessions. And it involves, 4 to 5 million injections. So just know, it's kind of like if you have a condition that's really serious, I really would recommend that you come down to Florida. If you have, a little bit of aching, this or that, you surely could look at, on Google, but realize 10% of our clients that I see, they've already seen other prolotherapists. And be very wary of doctors who charge an enormous amount of money and they're going to inject 1 or 2 shots in your neck with stem cells or placental cells or this or that and charge you $5,000 to $10,000. I mean, just don't do that. Like, it's a ligament problem. You need a clinic. And the other thing too about our clinic, beside the testing protocols that we do, which I think we're the only ones that I know of that do the, where we can test the autonomic nervous system, the blood supply, the instability, is that Caring Medical is a team. Like, we have close to 30 employees. So when somebody comes to see us, there's a whole team to take care of them. And a lot of the people, they need the whole team. The family's on the brink, the patient's on the brink, the kids are on the brink, there's financial issues. It's a nightmare. So in that sense, you really need the comprehensive team that we have at Caring Medical, and you need the experience like I have. I've just done this for 27 years. I myself have had cervical instability. I was in a terrible car accident when we were 14, 15. My dad was dropping me off at the golf course. Like I said, I've had drop attacks. I've had dizziness. I've had a lot of the symptoms, swallowing difficulties, a lot of the symptoms my patients have had. And there's something about having a doctor who's had what you had and has overcome it. And anybody who knows me, I've done 5 Ironmans. I run 3 times a week. I run a big center. And I can tell you definitively that prolotherapy has curative effects as it relates to cervical instability. Okay, so I think we're all done. And I just thank you, everybody, for your attention. And if you have any questions, just email at drhauser@caringmedical.com. Please see our website at caringmedical.com. Okay, I guess there's one more question.
What is the difference between what CM does and freeze-dried stem cells?
Oh, what is the difference between what Caring Medical does and free-dried stem cells do? It's mostly where the solutions are injected. When you get, like, Wharton's jelly or placental or freeze-dried stem cells, the doctors are using X-ray guidance to inject them into the joints. But remember I said, and normally it's just 1 or 2 shots. They'll charge you anywhere from $5,000 to $10,000 for one treatment. So what are the odds that your dizziness, your vertigo, your brain fog, and most people, they don't have $5,000 to $10,000 just to waste. So that's why I'm definitely not supportive of clinics like that. So I understand people go there and they're desperate and da-da-da. But you have to treat the ligaments. The cause of the underlying condition is cervical instability. So ligaments can only tighten so much per visit. So the solutions we use, if we're going to use stem cells, we want to use your stem cells. You have plenty of stem cells. So we get the stem cells from the bone marrow, from the fat. Oftentimes we don't even have to do that. We do treatments that tighten the ligaments. Once those ligaments are tightened, the symptoms go away and the person stops seeing doctors, stop taking medications. And that's all we hope for you. And I'll just leave you with this. This is, little things that I give out. This one says love. I love the color yellow. So I send my love to you, and so does my staff. And all we do is wish you the best of health.